Wilson Center's new program on global sustainability and resilience, of which the Global Health Initiative is a part. And I want to welcome you for what is going to be, I'm sure, an important conversation and I suspect a slightly different conversation than normally takes place, because that's the goal of everybody organizing today's event. On September 27th, the Program for Appropriate Technology and Health, PATH, released a report safeguarding pregnant women with essential medicines to the UN General Assembly. And the report outlines the paramount importance of medicines in preventing maternal deaths worldwide. And it also underscores the point that medicines can and should be made available so that where a woman is doesn't decide her fate. The report helps to highlight key interventions to reduce maternal mortality worldwide, and you'll hear more about the report in a second. So we have a great deal to discuss. There's a local jazz impresario, a former Redskin named Dick Smith, who's known for saying, "It's time for me to get out of the way and let him play." And that's essentially what it is. But before doing so, I just want to take a moment and thank the people who made it possible for everyone to be around the table this morning. Sarah Craven and her colleagues at the United Nations Population Fund, Tim Thomas and his colleagues at the Maternal Health Task Force, our own Sandeep Bathala, who many of you know, Thea Cook, Carolyn Lamere, and Payal Chandarami, who are here. Lauren Hertzer also has made work to make this event possible, and Rachel Wilson and her colleagues from PATH. So we've enjoyed working with all of you, and we hope to continue to work with you in the future. And with that, I am going to get out of the way and turn the microphone over to our moderator, Rachel Wilson.
Well, thank you so much for inviting us again. I think we were in this room here previously and had some conversations leading up to this report, which many of you contributed to. So many thanks to all of you who have lent your experience, ideas, and expertise to the conversations that all of us are going to have here today. I wanted to very quickly, although there's a lot of you in the room, just do one quick go round so you can say your name and your organization, nothing more. So we get a sense of who we have in the room, so you know who else is having this dialogue. So I'm Rachel Wilson. I'm the Senior Director of Policy and Advocacy at PATH. We're an international NGO working in global health.
Diane Seeger, The Washington Post.
I'm Tim Thomas from the Maternal Health Task Force at the Harvard School of Public Health.
Caitlin Worthen, Japango, Comendo.
Anit Malik, Medicine Sciences for Henry.
Jessica Anderson, Population Protection.
Susie Sacker, JSI.
Abigail Douglas, Active Associates, I'm of Financing and Governance Policy.
Carlos Indagochea, the George Washington University.
Marguerite Papiano, DAI.
Elizabeth Bedrenas, VOA. Lucy John, VOA.
Wang, UN Information Center.
Loretta Cruz, SEPA.
John Marazzo, USAID's Maternal and Child Health Division here in Washington.
I'm Sarah McKinney with the Press Newswire. Rachel Gandolf from the American Congress of OBGYNs.
I am Kyler Simon with Pathfinder International.
Janet Myers, International Medical Corps.
Suzanne Amers with PAI.
Vikas with JSI, Manager.
Paula Nersessian, Johnstone Incorporated.
Edna Jonas, African Strategies for Health Project at Management Sciences for Health.
Francisco Zamora, USAID Health Officer.
François Suisse Parizia, Action Police of Uganda.
Greg Simon, Global Network for Neglected Tropical Diseases at the Saving Vaccine Institute.
Ashley Rowe, the Pan American Health Organization.
Amanda Kiefer of Public Health Institute.
Judith Stanley, I'm a freelance consultant in nurse midwife.
Jillian Burkhart with PSI.
Donna Hakimian, the Office for the Advancement of Women, the Baha'i Community.
Jan D'Onofrio and National Health Office, Department of State.
Erica Bridge, Center for Health and Gender Equity.
Emily Bachman, the Department of Population, Family, and Reproductive Health at Johns Hopkins.
Lauren Herthorn, Environmental Change and Security Program here at the Wilson Center.
Edward Wilson, Johnstone Incorporated.
Payal Chandra Maheen, Environmental Change and Security Program.
And over here?
Jen Ferguson-Lockwood, USAID's Maternal and Child Health.
Ronnie Keith with PATH and the Reproductive Health Supplies Coalition.
Suzanne Diarra with Management Sciences from
Thank you all for doing that so quickly. And actually, we have a couple of other people here.
Charlotte Warren from Population Council. And Nancy Termby from Population Council also.
Since I had I was able to see the list and was so impressed with it, I thought you deserved to know who else was in the room. And it's a really fantastic mix of folks. Our panelist is equally fantastic. We've got Debbie Armbruster from USAID, the Senior Maternal and Newborn Health Advisor, who's been very engaged around maternal health supplies for a while. Long time. You used to work at PATH. Dr. Kennedy Chibwe with USP, and he'll talk a little bit about quality issues. We've got Kristy Kade from PATH, who oversees our family health advocacy and is the primary author of the report that hopefully all of you have received. We've got Jagdish from UNFPA, been very, very involved with the UN Commission on Life-Saving Commodities for Women and Children. Will tell us a little bit about that. And Stars, probably many of you know, has been an incredible maternal health advocate for as long as I've known her, and president of Family Care International. So thank you all for making the time, and especially Jagdish for taking the early train in this morning from New York. So I'm going to start by what we're going to do today is Jagdish will lay the groundwork for you a little bit about what this UN Commission on Life-Saving Commodities for Women and Children is and what the process is and where we're at with that, very briefly. All of us could probably talk about it for a long time. And then we'll have we'll have Kristy talk a little bit about what we found from the conversations we had with many of you and folks in a range of countries around specifically maternal health supplies, and what some of the policy implications are from those learnings and the agenda for action that we're hoping to see moving into the future. We will then hear from the others on specific topics in relation to what needs to be done to move that agenda forward. And so I've asked each of them to take just a few minutes because I am hoping that we can have a lot of time for discussion and dialogue because I'm sure many of you in the room have a lot to offer this conversation as well. So I'm going to start with Jagdish. You've been a major partner in the commission, and I think we have a few slides, if I can figure out how to use them, to lay out for us a little bit of where we've been and where we're going.
Okay. Thank you, Rachel, and good morning, everyone. Some of us were in Abuja last week, and one participant told us a story that I want to repeat here. She said in many countries, women go for delivery in operation theater, leaving their slipper or sandal outside, barefooted. And other people pray for her that she will be alive when she will come back. It's a story that emotional. And we cannot continue looking at the toll of women and children the same way it is going on forever. So this Commission for Life-Saving Commodities was established with that background, that we have to see what is the right way to address some of the issues more effectively. And we found that some 10 commodities, which we call underutilized commodities, can have an impact, very big impact, if they are accessible to everyone. And those commodities in next 2 years can save more than 6 million lives. What we need to do is to have a strength in ourselves, talk loudly, go and work with the countries. Governments are ready to work with us. There were 8 countries in Abuja with 200 participants. They were all saying that we know the problem, we know the solution. What we need to do is to scale up and work hard. I think that's the message that I bring from Abuja. So basically, 6 million lives for maternal health and children health. And there was also a big London summit on family planning, probably you have heard it, where experts told us that if we meet the need of 120 million additional women, we will reduce the number they told us is 300,000 fewer women and 3 million fewer infant death with the cost of only 4 billion in next 8 years. And they also told us the family planning alone can save 100,000 maternal death every year. Are we ready? Is this something that we should do? And we should do more, a bigger scale. For that is the background that the UN Secretary General announced the Commission for Life-Saving Medicines. Are we on the next slide, please? Basically, we are talking 10, it's very specific. We are not talking very big. It's a 10 specific, underutilized, high potential, high impact commodities. I will come in the next slide, I will tell you which are those. And then we looked at it, that what should be done in those commodities. And we found that there are 3 cross-cutting areas that are common for all those 13 commodities. And we thought that market dynamics, you know, there's not enough demand. So manufacturers are not ready to manufacture. And then you don't get the quality product. They are not registered. So there are more global level things like oxytocin, magnesium sulfate, misoprostol. You know, the price is not the issue. The issue is because it's too cheap, there's a market failure. The manufacturers are not ready to buy in a high scale. So you don't have pre-qualified, what we call pre-qualified manufacturer. Pre-qualified means WHO has to pre-qualify some of those manufacturers so that we can buy from them, saying that we have visited their factory, their GMP is right, they have all the right ingredient. So what women gets it? Whatever who produce it. Do we know the quality? Most of the time we don't know. Some of them are very good, some of them we don't know. And we have anecdotal stories that they have been given these commodities and they were not effective, and for that reason many people died it. And that's the experience that my team, they visited the countries, they came back. And then the issue related to, you know, the innovation. We still talk the same commodities without innovating. You know, some products require temperature control, and still we don't have it. I mean, it doesn't cost that much to have a temperature control. And we still talk. I mean, I have been talking this for 25 years, and we go on in the conference rooms and talk about it. What we need is to more consolidated effort, and media and all of you need to talk it more loudly. Next one, please. So basically those 3 are high impact, inadequate funding, and untapped potential. I will not read all this, but if you are interested, probably we can talk more about it. Next one, please. The 13 life-saving commodities I have listed in terms of reproductive health. There are 3, you know, female condom implant, emergency contraceptives, maternal health, oxytocin, misoprostol, magnesium, and same way for children health. And these are based on underutilized high potential commodities. And we are working on these, on specific commodities and also on what should be done both the global level and country level. Next one, please. And then for those 13 commodities, we have 10 specific recommendations. So we are not talking 200 recommendations and a big book and everything. We are talking only 10 specific. And when we have leaders like this, they want to even reduce to specific. And that's what we all trying to do it, saying that what exactly should be done in next 2 years? What exactly? What kind of market dynamics we needed? What types of innovation we need? How we can reach to last mile? I think that's the discussion we started in Abuja and coming back and then seeing that how we can. So all issue related supply, all related to is demand. You know, sometimes we think that it's easier thing that we supply and they will take it. Bring the quality product, people will take it. In Abuja, somebody told us, in many countries they have, you know, ORS is available, but people don't take it. It's health-seeking behavior is very different. We have to understand the culture of people, why people don't take it. Malaria-infected kids don't go to they don't take the malaria nets. Why? What is the health-seeking behavior? Why the people want more antibiotic in those countries than usual medicine that we will provide? Why? So we need to understand the country context. We have to understand the cultural context and health-seeking behavior to be effective. So all those things are global, country level that we will look at it and support it. Next one, please. And it's a bigger group, so it's not only UN agency. You have seen PATH and WHO and CHAI and all those key partners from civil society to UN agency to the government. They are part of this movement. Next one. And these are the commissioners, smart, known people. They committed themselves, CEO from the private sector. They said, we are committed. It makes sense to us. We will do whatever we have to do it. So it's a broader partnership. And that's the reason I flew from New York. Next step, I told you we had a wonderful Abuja meeting. We are trying to see that how we will engage with the countries, how we will make ourselves accountable, we monitor the progress, and how do we communicate, not only within the country, country to global, but with you, to all of you, saying that this is the progress that we are making and making ourselves accountable. That's about the commission. Thank you.
Thank you, Jagdish. What we're going to do is we're going to have brief statements and comments across this panel, and then we're going to open up for discussion. So please keep notes of your questions, and we'll certainly come to those. You know, a couple of things that we heard from Jagdish is that there's a significant amount of lives that can be saved, that these are underutilized, high impact commodities with a very focused set of recommendations. What I would say, just in follow-on to what Jagdish has said, is this report is not the end, but the beginning of the conversation. There's a set of recommendations, and now we're going to hear a little bit about how can we put those recommendations into action. One other thing I would like to note is that the Every Woman, Every Child website has a copy of the report. So all of the details that that you would want to see in there is online, as well as links to background documents on each of the different areas that went into some of the thinking that the Commission came up with. Next, I want to introduce Kristy Kade. She's going to provide an overview of the scope and breadth of a series of consultations that PATH conducted with our partners to help inform policy recommendations specifically for maternal health supplies. So while the Commission focused on 13 commodities across maternal, newborn, child health, and reproductive health, PATH worked with a number of you to dive a little deeper on the maternal health supplies component, which is a little bit different in some ways from some of the others. I think each of the different kind of groupings of commodities faces different challenges and has different opportunities. So she'll speak specifically to that.
Sure. Thanks, Rachel. Good morning, everyone. I think I have 3 minutes to cover what was about 6 months of work in terms of this report. So I will do my best to address all the different elements, but I will also rely on my fellow panelists to help illuminate these issues further. Before I begin, I do just want to thank and acknowledge my co-author, Lindsay Moore, who I believe is in the back or somewhere, and there she is, give a little wave, who also did a tremendous amount of work bringing to light and bringing to life your feedback in words and comments. I also really want to thank the audience for being here today to see so many interested in the learnings of this report on maternal health supplies for an issue that has often been overlooked and ignored. So it's great to see this issue be coming forth more into the light. And I want to thank so many of you in the audience who were actually also participants in the series of policy dialogues that informed the findings of this report. And I especially want to thank the Woodrow Wilson Center, not only for hosting us for today's event, but for really in many ways being an impetus for this increasing focus on maternal health supplies among our community. I believe it was at a meeting first held here at the Woodrow Wilson Center with the Maternal Health Task Force, Population Action International, PATH, MacArthur Foundation, a lot of other organizations I'm remiss in mentioning, who really felt there needed to be a formation of a maternal health supplies working group to really put together our heads and efforts and thoughts about how we can move this issue to the forefront of the maternal health community at large. So thank you everyone for doing that. We know maternal health medicines are safe. We know they're effective. We know they're essential to keeping women healthy throughout pregnancy and childbirth. However, we know very little bit about the supply, demand, and use of these products. And this is a huge problem for the supplies advocacy community. While I think everyone acknowledges easily the importance of supplies, there's very little a health worker can actually do when their supply cabinets are bare. It's been a significant challenge to advocate to policymakers for increased investment and focus on supplies with the paucity of data and documentation on maternal health supplies that currently exists. And the Maternal Health Supplies Working Group recognized very early on that as a community, we really needed to begin building the evidence base and essentially making the case for maternal health supplies. And this need really did accelerate with the formation of the UN Commission and its selection of 3 maternal health medicines, oxytocin, magnesium sulfate, and misoprostol, to be a part of its roster. The Commission really provided us an unbelievable global platform to advocate on the highest levels for maternal health supplies. And while I think there still needs to be tremendous long-term efforts to build that evidence base, in the short term, we felt it was really incumbent upon us to document the field experience that we know exists, to document your insights as experts in this community and in this field, and to really build consensus around some priority actions for maternal health supplies, both in an effort to support and continually inform the Commission at its global levels and now as it goes forward into working more at the national level. So what we did was between May, I believe it was May 2012, we began, in July 2012, we held 5 policy dialogues in Bangladesh, Tanzania, New York City, Seattle, and Washington, D.C., and more than 130 stakeholders participated in these series of dialogues, which represented regions all over the world and included many of you, as I said before. We had program implementers, advocates, health professionals, donor country representatives, and Ministry of Health officials. So it was a very diverse audience. And the goal of these dialogues was to identify, based on sort of your expert opinions and experiences, the major issues for action for the Commission related to maternal health supplies. This includes both the biggest challenges that really need to be addressed and potential solutions. Throughout this process over the summer, we did share your inputs and insights with the Commission as they were developing their recommendations in parallel. And many of the insights you will see in this report were also reflected in the Commission recommendations and implementation plan. There are still some gaps that you as a community have identified, and we're hopeful that those can be addressed kind of moving forward as the commodity and recommendation groups that Jagdish was discussing develop specific work plans, as well as when the country plans will begin going forward. But that needs to happen with the help of advocates and program implementers like you. The report we released last month captures, again, as I said, the major areas of consensus from these dialogues. And I would say those were really clear and overwhelming. There wasn't actually a lot of areas for disagreement, just places where more information was really needed. And this also presents what we hope is a targeted agenda for action for both global and national policymakers, advocates, and implementers, not just through the Commission, but through other vehicles and platforms and beyond. So quickly, I'm just going to go over the major findings from these dialogues. And I would just say that we could probably actually have a whole nother series of dialogues that really focus on the 4 major challenges that came out and really have groups sort of come together to identify, discuss, and kind of dream up some of innovations that really needed to meet these challenges. We really need to be thinking forth more through solutions. And so I would very much encourage those of you who have not participated to date to really participate in the maternal health supplies group that Debbie is leading in terms of developing the work plans for the maternal health supplies, where I think that's really where a lot of the solutions are going to come to light. How are we going to implement these recommendations going forward? Okay, so the major findings, as I touched on this a little bit before, but what we heard again was we need data and tracking. Unlike family planning commodities, for example, we have very little understanding of the actual number of women for whom essential maternal health medicines are not available. We do not know really the methods countries are using to quantify medicine needs and whether they're actually procuring enough to meet the needs of women. Manufacturers do not necessarily know how much medicines to produce to address these maternal health conditions as well. What's interesting, I think, about maternal health medicines that was discussed a lot during these dialogues was they're not being procured by the global procurement agencies. They're being procured at the national level and by local entities. And therefore, what really needs to happen is there needs to be a significant focus on strengthening local and national data collector systems in order to improve the forecasting of supply, demand, and use of maternal health medicines. The main recommendation was really the need to integrate data tracking and analysis of maternal health medicines into existing LMIS systems. And there was also a strong emphasis on bilateral programs to provide the technical assistance to make that be able to happen. There's a lot of conversation in terms of integration and service delivery. And there was hope for a lot of integration in how we approach commodity work, and not just supply chain when I say that. But there is the hope that programs that focus on commodities and strengthening data collection would be a really missed opportunity if we don't begin integrating maternal health medicines into those potential programs that were raised, and or for example, is like the Deliver program, and a more emphasis on maternal health medicines might be a really valuable policy change and emphasis and program change. Quality was a major issue. The poor quality of medicines were raised again and again, and that's also a huge focus of the Commission as well. But there is a real emphasis in the Commission in terms of focusing on global manufacturers and ushering them through the pre-qualification process. In terms of the maternal health medicines, and I hope Kennedy will talk more about this, since they are so often procured locally, there really needs to be the focus on building local capacity for quality insurance. And unless we can really address that, we feel the issue of not enough potency in a lot of the maternal health medicines that reach women will not be adequately addressed. And this is where a lot of brainstorming and creative thinking needs to happen in terms of developing solutions to address this issue of local quality assurance. We heard a lot about the need to integrate and innovate for improved maternal health commodities. There was a lot of emphasis on wanting to integrate oxytocin into the cold chain. While there is opposition from that in other circles, it was strongly felt among the maternal health community that needs to happen. Innovations such as new heat-stable formulations for oxy, more durable, moisture-proof packaging is incredibly important for misoprostol tablets. Other innovations include, separate packaging depending on purpose for misoprostol and oxytocin, developing a simplified dosing regimen for magnesium sulfate to make it easier to use. But the other really important critical aspect was not just making sure these innovations happen, but having donors, national governments play a large part in investing in the market creation for use of these products. Maternal health medicines in many ways are very cheap, and a lot of the innovations might be more costly, but will also expand access to women. And that is something we have a discussion about, is that a cost we're very willing to pay. Misuse was a big issue that came up in terms of maternal health medicines. Misinformed healthcare workers incorrectly administering oxytocin to augment labor as opposed to using it for prevention of postpartum hemorrhage. Fears of magnesium sulfate due to its toxicity and people not being wanting to use that. These are examples of common misuse that needs to be addressed. And there was a really strong need to enhance policies, knowledges, and skills. This real ground level work needs to be a focus as part of the commodity work plans and the national planning of the Commission. We're not already included. Oxy, meso, and magnesium sulfate should be added to essential medicines lists, standard treatment guidelines, and national protocols. And there needs to be a facilitated effort to help education and training among healthcare workers, both in pre-service and in-service. Now, I didn't get to everything, but Rachel sent me like a note like 5 minutes ago that I was way over. So I really quickly rush and collapse some of these issues, and hopefully during the panel discussion we can get to more of them. So I do apologize for going over.
No, thank you. I can't say enough how important having an agenda is. There's so many things that we can take on in this area. There's so many needs. We recognize that the commodities and supplies component is only one part of that, but at least we're having an opportunity to do a bit of a deep dive into that area and add that to the conversation. Kristy highlighted areas of data, of quality, of innovations, both in formulas and packaging. Innovations in delivery and looking at integrated systems, misuse, the need for policies, and I would say overall, part of the reason for the report is the need for political leadership and political will at the global level, at the national level, at the subnational level, to make sure that that these policies and priorities get into place. I'm going to segue over to Kennedy because one of the issues that we did hear a lot about was quality. We would hear in some countries that there'd be 40 different formulations or 40 different manufacturers of one type of drug, and that countries didn't know which ones to use and which ones were of high quality. I know that you have done a lot of thinking about that both in this area but in other areas, and I'm curious if you can tell us a little bit about what you've learned about incentives for local manufacturers, how we can enhance the quality assurance process, and how we can take some of the learnings that have been done in other areas to inform maternal health supplies.
Thank you so much, Rachel. First, I just want to acknowledge, I want to thank the panel and the organizers, PATH, USAID, and others involved. I just want to thank everybody for inviting me to participate in this very important panel discussion. And the reason I'm very motivated about this, I originally come from Zambia, and I know what it means for somebody not to get the right medicine and the impact on families. So it's something that really drives me, and in fact of self-introduction, I'm representing promoting the quality of medicine, which is PQM. It's USAID funded, and you really have to applaud USAID. They've had huge impact in having this program implemented with USP, US Pharmacopoeia. And we've learned a lot, and since I'm just given 3 minutes, I can't talk about all that. But what I'm going to do is I'll summarize. I'm very good at summarizing, and my wife keeps complaining I don't talk enough. So you shouldn't have a problem. I think one of the key things that we've learned, even working with the pre-commissioned technical group that I was involved in, is really the key things that are involved. One of the things that Jagdish just pointed out is there's a lot of talk. People can talk and can give very elaborate illustrations on what the solution should be. But what is always lacking is a practical approach. In this case, when it comes to really having commodities that are needed, one of the problems is that commodities are available and they're in abundance and they're cheap, and any manufacturer can make it. But in most cases, they are either counterfeit or substandard. And that's a usual culprit, and that's a usual problem. And from our own experience, Rachel, even as I pointed out before, we've had experience in terms of trying to streamline that process. How do you start? How do you practically change the mindset in a country and also at national level? The first step really is to influence the policy at the procurement agency level. Whether it's an NGO, whether it's UNICEF. In fact, later on I can give some examples. We've worked hand in hand with UNICEF to actually do exactly that for zinc supplies. So at the national level, the key piece has to be demanding quality products. Okay, what does that mean? It simply means they're only going to work with the manufacturer. The simple example that I give is overly simplistic. Essentially, if you want to get some food for your kids, you want to make sure that the chef, you can trust that kitchen. It's not dirty. It's clean. So essentially, you want to have a manufacturer that has been inspected, that meets what we call minimum good manufacturing practice, GMP. And it's not a separate GMP for third world and developed world. No, it's the same standard. So what has been able to be done in the past and continues to be done even now, and I could give examples later on, given 3 minutes, I can't give too many examples. But essentially, it's possible to actually get the correct chefs, get the correct suppliers, and have the national procurement agency, maybe the government, like for right now we're working with Ghana government, and the procurement agency demand that and essentially also request technical assistance from groups such as PQM, and we're able to actually work with the manufacturers and try to bring up their standard to where actually even WHO, if they came in, they would say, yes, this looks good. And I can say that because we actually now work with the pre-qualification group, WHO, for second-line TB medicine. With USAID funding, we have very good support to actually bring up manufacturers to supply second-line medicines. So we use that experience in working with manufacturers at different levels. We've worked with zinc, for instance, the ORS, for manufacturers for local supply. And it's very possible to actually have a policy that would demand quality in those products. Because if you don't have a good product, you might as well just be distributing candy. So there's no impact. So it's actually more sad. I think there's a quotation, I don't recall who said it, but it says, it's easy to understand somebody dying from a disease, but to die from medicine is inexcusable. So, thanks.
Thank you very much, Kennedy, for that and your perspective. I think some of the things that main points that I heard you say is that it's critical to work with the procurement agency, particularly at the national level. That there needs to be demand for quality products. And part of that is also education of the political leadership who are doing the procurement to understand quality issues. So again, that demand, I think, will be a common theme that we'll hear throughout. That technical assistance is often needed to help the countries in enhancing that capacity. And that we have things, this is not the first time that we're addressing these issues of quality of drugs, that we can learn from other experiences with TB drugs, zinc, ORS, and other areas. So thank you for that, and I hope we do get a chance to hear more of your stories and experiences later. Next, I'm going to turn to Debbie Armbruster from USAID. Quality, so even when quality health medicines are available, and that's an if, because it doesn't always happen. Another challenge that was highlighted in the report was that providers don't always know how to use those drugs. We look at magnesium sulfate, for example. And so I'm wondering, obviously training is the first thing that we heard from people when we had this discussion, and that's important. Maybe to say a little bit more, how training can be embedded, but also beyond training, what are some of the things that you can see might be able to be done to help make sure that the drugs are actually being used correctly and effectively?
Thank you very much, and I just like the previous speaker, Kennedy, I'd like to thank all the folks who have organized the panel, and I have worked extensively with the partners from PATH and actually many of the people in the room to kind of move the work of the commission forward. So I think it's exciting that we're here, and there are new folks in the room, which is exciting. So folks who haven't been involved in this work, there's lots to do. Please make sure we have your names so you get on the lists. So I'll start with a little plug. I think the whole issue of training, we have trained, and that's kind of where I began. And it continues to be really what clinicians want, and I think people want to learn. And there's also the whole issue of per diems, but in general, I think there's also they really do want to learn. I think that historically we've had like these longer trainings, but I think there are more and more ways in which people can learn on the job. I think there's a lot of alternative ways, and many of the people in the room are using them. I think there's the job aids. There's some fabulous job aids out there now. Electronic kinds of, I wouldn't say mechanisms, but ways to do training. And of course, as we all know, many ways that mobile technology is being attempted to be used. And I think they all have important things to offer. I think we need, and I think this is probably where we fall down with training, is that we don't evaluate well enough. We don't find out, and we probably 10 years ago we started talking about performance instead of just training. are we actually changing performance? Are we changing the behavior of providers? And I don't think to date that we still use that information that we know to evaluate and follow up to ensure that, in fact, people actually are practicing what officially they learned. I think we need to remember they need to start off right, pre-service. Now, there are more and more groups working with pre-service training. How effective are we in updating and putting enough money into pre-service trainings so that, in fact, providers even come out knowing correctly what they should be doing? I'm thinking about, one of my issues has always been the clinicians and like the family health division at the Ministry of Health never talks to the central medical stores people. So in fact, the procurement that's happening isn't connected to what in fact's needed. And then we have the issue of the central medical stores may know how to store these meds, but the people who actually do the storage are these clinicians out in the clinics, and they never learn. I mean, how often have all of us gone out and found ergometrine, oxytocin sitting on the shelves? And you know, what happened here? Was it training? Was it information wasn't shared? You know, I think we've got lots of issues. Actually, a really interesting one, in Abuja, one of the things that came up was package inserts. I mean, are they in the local language? Can the providers who are even using these meds understand what they should be doing? So, I mean, there's lots of stuff that needs to happen. And kind of this whole issue, I don't know, cross-training. I think it has many meanings, but I think the whole idea of different cadres talking to each other would be really helpful. I think we have the challenge of staying updated. I mean, one of the things that was told to me was, well, why should I bother updating my guidelines? Because you guys are going to change them next year anyway. So it's true. It's an ongoing kind of issue. And how do we, you know, get providers ready for kind of on an ongoing basis, things are going to change. We're going to have new evidence. So, I mean, that I think is a challenge. Chlorhexidine. I mean, how many providers out there? It's the new, you know, drug going to save lots of neonates and newborn lives, but how far out, how are we going to share that information with, and now cotrimoxazole. I'm looking at Judith over here. Cotrimoxazole is, you know, a life-saving drug, but now we want to move that out because it's not the hot drug, it's now dispersible amoxicillin. So just keeping people up to date and is, I think, a challenge. One of the things I think is very exciting is quality assurance programs. And if I was going to put my money someplace, that would be a place that I would put it, because I think that at least a lot of the quality assurance programs, and I know some of the ones that USAID supports, actually empower providers to figure things out themselves and figure out how do you keep yourself updated. So I think, again, that's another way that we can do things besides training, I guess. And one of my favorite articles, I mean, there's lots of research out there. Behavior change and behavior change methodologies, it's not sexy for clinicians. They like trainings. But there's a great group in Argentina that did fabulous research on very simple ways to change. They increased the use of active management by like 65% and decreased use of episiotomies by 80%, just using simple behavior change methodologies. And has that got taken up? This is like 5-7 years old now. No. So there's a lot of things we could be doing that we're not initiating. Then there's the financial incentives. I bet you didn't know I had so many ideas, did you? You know, the PBFs, the PFPs, all the different initials for how you do financial incentives. Again, I mean, I think that there is real value in a lot of it, as long as we connect quality and it's not just coverage data. It's not just bringing them in. It's ensuring that, in fact, we do it well. And I'm trying to think. I think I've covered most of it except innovations, and Kristy talked about that. I mean, mag sulfate scares the bedoodles out of a lot of providers. I mean, could we have everybody order, and I'm going to be talking to Jagdesh & Co. and WHO, just 50% solution. Let's give everybody 50% solution. Let's have WHO say that. Instead of the 20s and the 15% and the 40% and the 45%, I mean, how are you going to calculate that? No wonder they're all afraid to use this stuff. And boxing it, the MAGPIE trials, the big MAGPIE trials, actually boxed up what exactly you needed for a loading dose for mag sulfate. And I have been talking to my friends at PATH about this for a long time, and we haven't gotten very far. This was long ago, but I think there are things that we can do to simplify it and make it easy for providers. And then there's good old Uniject, which I still think is a great product. But, you know, it's the weighing the cost and the benefits. So I don't know if I'm over my 3 minutes, but those are my ideas.
That was wonderful, Deb.
I want to hear you summarize that, Rachel.
I'm going to do my best.
I'm waiting for that too.
I like a challenge. So, I mean, I think some of the key things that I took away from that, Deb, is that we need to evaluate the effectiveness of our trainings. We've got a million different ways of having trainings, and what's really working, right? I mean, item number one, it's not just about training existing folks who are out there, but pre-service training, investing early. Part of what you also talked about was that it's not just a matter of training the clinicians, it's also a matter of training through the procurement, storage, packaging process, and making sure that there's linkages between those and some cross-training even.
I'd even talk about task shifting. Forgot about that one. Just thought I'd throw that in too.
Well, maybe Anne can get a little bit to the task shifting. But the fact that people need to have a way of updating people as new innovations and new processes are coming underway, that we have to look at behavior change not just by the kind of the patient model, but that we're behavior change of clinicians, and using some of what we all know as public health practitioners with our own fellow public health practitioners. Financial incentives, packaging and dosing, and with Uniject, for example, you could promote task shifting so that lower level cadres of workers were able to give an injection of oxytocin. So yeah, I got it in there for you. Along the same lines of task shifting and the role of the community, I'm going to give Anne an easy one, right? Never. That a lot of people in the maternal health community believe that the drug misoprostol, which is one of the three, has a potential to really transform maternal health, and yet there's a lot of controversy around it. Not just abortion politics, because misoprostol can be used as an abortifacient, but concerns that it flies in the face of efforts to get women to give birth in facilities. So you've got a whole list of kind of political challenges to this drug, yet some incredible opportunities for women having access to a life-saving medicine. I'm curious, given all of these both challenges and opportunities, if you can tell us a little bit, in particular for those who may not know as much about this, about where can we go? Where are the possibilities with this and community level impact?
Great, thanks, Rachel. Is this on?
Yep.
Okay. Yeah, I think that there's been tremendous changes and tremendous progress with the drug misoprostol over the last few years. And I think particularly in the last couple of years, we've seen some real developments on the policy and normative side that provide a huge opportunity. Family Care International, my organization, has been working on this area, working with Genuity Health Projects, which has been doing a lot of the clinical research around the impact, dosage, effectiveness of misoprostol for both prevention and treatment of postpartum hemorrhage. And we've been working more on the advocacy and policy side and have done a series of mapping exercises and conversations, dialogues with policymakers and clinicians in developing countries to try and understand what are the perceptions and what are the obstacles to widespread adoption and use of misoprostol for PPH. And Rachel has touched on a couple of the key obstacles. It varies a little bit by country and region, but certainly one of the key ones has been this perception that misoprostol is, the reality that misoprostol can be used as an abortifacient, which is seen as a real challenge, as a real obstacle in terms of its widespread use and adoption. And I think the key development there has been, the key developments that have helped in terms of addressing some of those concerns are the WHO decision to put misoprostol on the essential medicines list in 2011, and then most recently the development or the issuance of clinical guidelines on the use of misoprostol from both WHO and then just most recently from FIGO, from the International Federation of Obstetrics and Gynecology. So having that very high level approval, stamp of approval of misoprostol and the specifics on how it can be used is just, it's invaluable for encouraging the appropriate policy and normative guidance to then be incorporated into these ever-changing clinical guidelines, as Debbie mentioned. I think turning to this question, and there has been tremendous concern around this issue of if we make misoprostol available for use at the community level, distributing it through community health workers, through traditional birth attendants to women directly, is that going to discourage women from delivering in a health facility with a skilled birth attendant? And I think the answer to that is, well, we need more research on that, but certainly from some of the pilot studies that have been done on the use of, or on the distribution of misoprostol at the community level, there isn't any evidence that that is happening. And in fact, some of the studies, for example, one in Nepal, showed that if it's done well, if part of the rollout of community-based distribution of misoprostol is to encourage birth planning and birth preparedness, that it can actually potentially even increase delivery in health facilities. So I think the answer to that is that it's a lot of it is in the planning and how things are rolled out. If you're aware of what some of these challenges and potential obstacles are, then they can be planned for and addressed in the rollout process. As I said, we definitely do still need some more work and some more research, and we need to look at how to scale these things up effectively. And we also need to deal with the possibility from an advocacy and communication side that there are going to be some cases where misoprostol is used as an abortifacient potentially, or where it's used inappropriately to induce labor. And we need to acknowledge that that's going to happen and be prepared to respond to that from a communications perspective. And the key thing there is just to talk about what the tremendous impact of community-based distribution, community availability of the drug is in terms of preventing and managing postpartum hemorrhage.
Thanks so much. I mean, I think there's a lot we can learn from the incredible amount of work that's been done in a really relatively short period of time by a lot of groups working on this. Dispelling some of the misperceptions of some of the things that you've mentioned, planning and being prepared. Really, I think learning, sometimes we as a public health community don't always learn from our experience. And so I think that, very well said, and I think all of us to take heed, is that there has been a lot of experience, and we need to learn from that. We need to work with governments and communities so that they can understand where others have had challenges so that we can learn how to overcome those. And also the importance of research and continuing to take that research to inform where we move into the future. I'm going to loop back to you, Jagdish, full circle, and just maybe say, since you're with UNFPA, a little bit about, we've learned a lot from the reproductive health community and increasing access. I mean, we've seen some incredible advances, in particular with the latest commitments around the Family Planning Summit, and some of the tracking and the data that we've recently been able to maximize through some of the programs that you have. Any lessons learned from some of that that you think we could learn, take from the some kind of the contraceptive commodities world to inform some of our maternal health supplies work?
I'm trying to connect family planning and maternal health group together, and because I'm in both sides, I know maternal health side is not in the same playing field. In terms of, I know JSI and so many agencies have been working in family planning areas for so many years. They have done tremendous work in understanding demand, supply, quantification of needs, the whole supply management. They have gone to at least the district level from the central level. I think the issue is how do we go from district to the community level. That's the issue that we, even in family planning side. But we know that if we have resources and we have that the human resources, both the financial and human resources, probably we can do it. But in terms of maternal health, I think it's not so much not knowing at the country level what is needed, because it's the simple formula. I think what is needed is to see that how people are consuming. What is the consumption data, let's put it that way. How much people are using and not using it, what kind of formulation they are using, what kind of quality is available. Do the providers know the right formulation? Are they available in the right temperature. So all that consumption data and need data has to be quantified at the country level, but also the global level, so that we can do more global dynamics, the more market dynamics, talk to manufacturer and say that, this is the demand and this is the supply, and, how we can help you to produce in what Dr. Kennedy said, that in the quality GMP, and then we can rest assured we put our stamp and say that, these are the manufacturer we pre-qualified, and you can buy from them. So that work, we need to do it. I think we are coming closer. Both Family Planning Summit in London and UN Commission, I see many common friends together, and we are bringing that knowledge. Even in maternal health medicine, in Abuja meeting, many countries told us that it's not reinventing the wheel. There are so many things are happening there. I think what is needed is to the recommendation that we identified and how we scale up and see the specific thing in the specific country. So it's not the common in many countries. Every country is talking different language to scale up, and in some countries some issues are different than others. But I think the issue that we are coming together, and there are lessons learned in terms of quantification, in terms of registration, in terms of pre-qualification, in terms of behavior change communication and other things. We can learn from each other, and that's the challenge that we have taken. So in nutshell, I think what I'm trying to say that we don't have to start from the scratch. We are very much there. I think we need a little bit push both from political side and technical side, and with resources and some policy guidelines and coordinated effort. What Debbie was saying, that within the ministry there are like 4 or 5 divisions, and they don't talk to each other. I think the challenge is how we bring integrated way so that family planning truck goes in one time and maternal health goes the second time, the same place, and then we incur the cost. I think those are the things that we need to integrate, and I think the governments are ready to listen to this, and they are taking ownership on this. So that thanks to the government leadership and national leadership on those issues, and we have to work with them on, and we have to support them.
Thank you very much. I'd like to open it up to all of you. Do we have a mic somewhere, I wonder? We do. We have a roaming mic over here, 2 of them. And so if you can raise your hand and remind us who you are and where you're from, and who you direct your question to, that would be wonderful. I have one person here and here. She's bringing you a mic right there.
My name is Françoise Risa-Kayuzia, and I'm from Action for Reproductive Health. I did found the organization, and it's operating in Uganda. I do have a problem with the approach of everything. What they said is really good. If it can work on the ground, it would be very wonderful. But when you look at it, maternal health happens in developing countries, and most of these countries do not have the capacity to manufacture maternal health medicines. When we talk about demand, who defines the demands? We have the government, we have the health professionals define the demands. Then when we go to supply, who supplies? Since we are saying that these countries do not have enough capacity to supply, they settle for whatever they have, they are provided with. And in most cases, they settle for the least, because they don't have the capacity to buy or to even produce the medicines. That affects the quality of the supply. The other thing is, when the supply is there, how much supply do we have on the ground? Then most of what I have heard have left out the consumers. You may have the demand, you may have the supply, but if this consumer is left out, where does the medicine go? I do work with the communities, and what I've seen with the governments, they do work from up down. They leave the communities out. When you leave the communities out, what that does is the communities are not going to come out and use the medicines that have been produced. And that doesn't work well. I did work with maternal health for over 20 years, and most of what I saw was expired drugs, which is really sad. How does that work, or how does that help the consumer? The other thing is, when we talk about the consumers, how the communities in most cases are left out, because perhaps they assume that these people don't understand what they want, and at the end of the day, they don't go for these the commodities that are out there. I'm thinking about the family planning contraceptives. The communities that we are working with don't have a clear concept of what these are, because when we are preaching about, when we are talking about condoms and pills, we emphasize more on the pills and the condoms, and we leave them out. We need to bring them up first to make them the first issue, and then these ones come in as to help them. Otherwise, they are rejected. They don't want them. Then among the things that I had, but I didn't hear something to do with morning after pill. I'm not an advocate of abortion, because the communities that we are working with don't understand what abortion is. To them, abortion is death, is killing a baby. Most of these are religious people, Christians, Muslims, or whatever. And when you talk about abortion, that doesn't work for them. So that one is a little complicated. However, if we perhaps advocate for things like morning after pill, maybe that can make some little bit of sense, because we have rapes, and rapes don't only happen everywhere else outside. Yes, they do, but there are rapes that are not talked about, and those are rapes that happen in marriages. I'm working with families. Rapes happen in marriages every day, and these rapes are not talked about. At the end of the day, a mother is going to have 10 babies, 10 children, and that's postpartum hemorrhage out there. They think about abortion as, the way it causes the stigma, the time it consumes, the place, the personnel that's going to be involved, the drugs, and then the money. That's not viable because these communities don't have money. So if perhaps we can approach it in a different way, maybe that would help. Thank you.
Thank you very much for your comments. There was a lot there, so I'm going to try to bucket a couple of them. This panel is actually focusing more on the three that were in the three commodities that were in the UN Commission. I think you raise a great point that, first of all, family planning is a huge component of maternal health. Second of all, that this is a limited scope of commodities that were in this report, and I think the panel will recognize that it is limited. So those points absolutely taken. I think two of the main things that I heard you ask about was around quality, that there's an acceptance of lower quality because it costs less. The other was around demand and community engagement, and where is the community in this process. So I'm going to ask, put this to our panel, and any comments or responses that you'd like to make to any of these comments. Jagdish?
I think, Francis, what you are talking, we all saying the same thing, it seems to me. You made a wonderful points. And I think the whole discussion from Kennedy talking about the why quality is important and why it is important that we should not accept it. There is the value of community engagement are a great point, and we are together with you. I think in terms of family planning, let me start with the family planning, and probably we can quickly run through other issues. I totally accept your point that if we don't engage community and talk about the product without talking to the community, we are going to fail. And those countries where contraceptive prevalence, as we call it, the number of contraceptive uptake, is low, where community is not involved. And in those countries where they have done lots of community extension work or community outreach, and that's what Debbie is trying to say, the task shifting. For example, Ethiopia recently did a wonderful job, and Rwanda did. Uganda is coming up bigger way in getting more community involved. And that means that you start from bottom-up approach. You talk to community and see that what are their needs rather than talking the product, but understanding their needs and then suit the product. We are also seeing in the last 3-4 years, which I have not seen in so many, in so many years, is the interest for looking at more long-term method rather than just talking, the short-term methods. And we have seen particularly in sub-Saharan Africa, the needs for long-term methods have grown up so tremendously because the community was saying that it takes us so long to come to the community, the facility level. And then sometimes there are stock out. In many facilities, there is stock out. So we have to go back. If we have a long term, at least we are rest assured for a number of years. So that upsurge in in the community level, understanding community level, and defining what is needed to serve them. It's coming up. I mean, it's coming up big way. In terms of maternal health, I will leave with the other panel to talk. I think it's a community demand, but also it's the provider knowledge and also the product itself. I mean, there are all three components. The community is important, but there are components of the quality available, and there are not manufacturer, then what are the other ways to get it, and who are the manufacturer where we can get it, and what price. And then the issue related to providers. Do they know it? Do they have a proper training to provide? And do they have proper stock in the quality that you are talking about it? And all those issues are in the terms of those 10 recommendations we try to summarize. But I will leave with some of the experts here to talk more about it.
Just really quickly, and picking up on this question of the engagement with the community and how do we define demand, not just by in terms of what healthcare providers or even health systems are saying, but really what are women and community members saying. I think misoprostol is an interesting drug in this respect because there have been some efforts to a few pilot efforts to really reach out to communities, to women, but also to key leaders, decision makers, religious leaders, and others in the community around the effectiveness and impact of misoprostol, and have had tremendous success in that area. I think, stepping back for a second, the HIV/AIDS community a number of years ago when antiretrovirals first came out really led the way in terms of there was a very, very widespread response when the idea of making ARVs widely available, particularly in rural Africa, was being discussed and was being proposed. And there was a strong reaction from many parts of the medical community saying, we can't do that. These drugs they're complex regimens, et cetera, et cetera. If we make them available at the community level, people are going to use them incorrectly and we're going to end up with these huge problems. And there's often that kind of response from the medical community. But I think, as I said, we need more evidence. We need more research on this. But I think there is sufficient evidence even now to demonstrate that if community education and outreach is done appropriately, if it's culturally appropriate, if it's sensitive to the perceptions and the attitudes and priorities of people in the community, that the impact and effectiveness and value of these kinds of technologies, of medications can be explained to them, and B, that they can be used appropriately and effectively at the community level, some of them.
Go ahead.
Okay, that's fine. I think I want to address some of the issues on quality that you raised. One of the things that you mentioned was about expired drugs. That's a huge problem, not only in Africa, Southeast Asia, and partly also in Latin America, we see the same problem. So that's really has to do with the regulatory agency in the country. The capacity of that regulatory agency, if it's anemic or it's not even there, you're going to have that problem. There are certain interventions that can be done, and I'm not going to be talking about our program because that's not what I'm here for. But in terms of, in general terms, what is needed in a country is really to get the support they need. WHO could provide some of that support. USAID can provide some of that support, and they could approach country mission in country. So essentially, you could have programs designed to support the regulatory agency to enforce. Just like in this country, we have the FDA. If a manufacturer makes some bad medicine, they'll visit them and they'll find out what went wrong. But there's a law and there's enforcement as well. So that's really what is needed is regulatory agents in country to be able to actually have the capacity to enforce. It's a sad story at the moment because if you really look at these counterfeit and substandard medicines, it's a huge market. It's about $70 billion worth. So folks will make counterfeit medicine and sell it. I mean, they're even trying to sneak it into this country. So it's really a huge problem. I don't think you can solve it overnight. But what I would encourage you in country is to engage the regulatory agency and see what support they can get to actually design some interventions. So that's about drug and the quality in general in the country. But you also raise questions about manufacturers. I mean, we can't find them in country. That's the reason the commission was put together, is really to try to see where the need is. And at this moment, if we don't have data, if we don't know what the need is, it's very difficult even for the manufacturer to make. These are very low-cost products. But if the need is defined and the demand is there, then the local manufacturing is also possible. What is anticipated at this point is that whatever manufacturers at least that meet the GMP standards, those would supply. If they get WHO pre-qualification, for instance, or if they are supplying a specific commodity in a specific region, we'll make that available. That information, I think, will be up to the country to actually find out who is the supplier. And that's the reason actually it goes back to my initial statements about the fact that the procurement agency need to demand quality. And they need to get that technical assistance on how they're going to make that demand. UNICEF has very good experience in this, and I can vouch for them because I've seen what they've done, and we've had some opportunity to work with them for zinc, for instance. So that's something that's possible, that at local level you can have a manufacturer that's already, in Uganda you have manufacturers there. They are making, it's almost like you have kitchens and chefs. We give them a recipe, and the recipe usually is going to be a monograph, could be WHO monograph, or USP monograph, or UK monograph. But there has to be a recipe that probably WHO may actually list on the essential medicines that even any local manufacturer should be able to pick up, be inspected, and meet the minimum general good manufacturing practices, GMP.
And I will also say that one of the things that the Commission has been really kind of struggling with is how do you create incentives? So what you're saying is, there is really no incentive for the higher quality. People are going with what is costing the least, I think is what you were saying. And so I think that being really creative and looking at how incentives may be a factor is something that a lot of people are grappling with for the very reasons that you've stated. Debbie and Kristy, quickly, and then we're going to get to some other questions.
Two additions. One is that there are two recommendations specifically addressing, I wouldn't say the community-based, but the demand issues. And actually USAID does convene or is kind of leading one of those. So, it is recognized that it's an important point. And the majority of what they're looking at is how do you ensure that communities are engaged or that that there is enough information for people to make choices. So I think recommendation 7 and recommendation 8, which is trying to actually ensure that we're reaching the most vulnerable. And that gets clearly into the communities as well. And it's not just communities, but it's the poorest and the least reachable in the communities. So that's also an intent from the Commission. The other thing that we haven't talked about at all, because we've all been basically talking public sector is private sector. And that's a whole nother issue. And how do you ensure quality there? And I think we've, some of the data that one of my colleagues recently pointed out is in Asia, more than half of healthcare in general is provided by private sector. And so even in countries where it's majority public sector, They stock out. Where do they go? Local pharmacy. So the issues are bigger than just the public sector issues. Okay.
This question's been addressed, so I'll just really quickly say I think your comments about the community have been highly recognized by the Commission and this group as well. I was remiss in not being able to get to that piece of the report, but when we were with MSH, USAID, UNFPA, doing sort of all the background review for maternal health medicines to ultimately feed into the Commission, this was sort of the issue. There wasn't actually a lot of information about consumer preferences, demand, and that was what was said by this larger community as one of the key focuses that needs to happen, and putting emphasis on that, therefore. And it is being carried through and carried forth through the Commission. And I would just say I think your comments show how complicated and difficult this is, and what a huge challenge the Commission has before it, because things really do vary country by country. In many places, there is the local manufacturing of the supplies, and that is where the purchasing is happening, and then there's the low quality issue. And then other countries, it's different. And the challenge of finding recommendations that are cross-cutting and high level and can really address the gamut of issues is critical. But I think this is at the national level where so much is really going to start, where the rubber meets the road, and really trying to develop those national level solutions that will implement the recommendations as necessary for that country context.
Thank you all. Other questions? We've got one right here.
Hi, is this on?
Yeah.
Hello? Okay. Hi, Lorette Kakuza with SEDPA, Senior Reproductive Health Advisor. And this question is more for Jagdish, I think. I was very pleased, actually, to hear Rachel say, family planning has been critical to maternal health. And I think there's some artificial divide that has happened, and integration being one of the recommendations is, I think, a wonderful thing. And I'm just wondering, in terms of that integration, I know you've worked with the Reproductive Health Supplies Coalition, so how will the Commission's work overlap or integrate or, work with that advocacy work at the global and national level?
We're still working on it. Let's put it that way. We invited Supplies Coalition as one of the working groups, and they're part of many working groups. But Supply Coalition is the only partnership. We all are member of Supply Coalition. So whatever we experience, we gain the experience on commission. We go back to coalition and we talk about it. And I gave presentation in Paris when the Supplies Coalition meeting happened, and I informed them what is going on and invited people to be part of it, the commission. So many members became a part of the working group. So, it's a slow process, but I think, because if you see the family planning and maternal health history, there is a big divide, and we all are responsible for that divide. But the time has come that divide has to be integrated. Otherwise, we cannot go on saving women's life by just doing family planning or just doing maternal health. And as I said, sending 2 trucks in the same place by the 2 different departments, this is not acceptable. We will not, and countries are saying it's not acceptable. It's not us, but the countries are saying that please come integrated. So when UNICEF and even UNFPA, I go together with UNICEF, they are very happy that you are talking even children health, you are talking family planning, you are talking maternal health. It's a really continuum of care. And that's what we need to do to countries, to save them from the transactional cost and say that this continuum care is the key thing to see the whole spectrum, rather than because we are divided, we are trying to divide the countries. So you're absolutely right. We have to do more, and there are many coalition friends are here who are working in both sides, and we need to bring them together both to bring the family planning perspective up within this continuum care, and which is great because 1/3 of maternal death can be saved by effective family planning, and that's what we need to do it. And the recent announcement of implant price by Commission was the great news that we celebrated in coalition. It reduced by, I understand, less than half from $18 to less than $9 or so. This has never happened in 25 years of history of family planning. So those are the things are coming together. I think that's the great news.
I'm going to put my colleague from the Reproductive Health Supplies Coalition on on the spot here. Bonnie, can you just say a brief comment about the Reproductive Health Supplies Coalition and its engagement around maternal health?
Happily. So yes, I'm Bonnie Keith from the
Stand up.
Reproductive Health Supplies Coalition. I can stand. Sorry, I have things in my lap. A number of you in the room have been engaged with us not only for our work in family planning, but over probably about the last 18 months in the efforts we've recently undertaken around maternal health supplies. We formed an interim task force about a year ago, last November, that met for the first time last November, and the goal with that task force was to talk about how the coalition can add value to the maternal health community in efforts to address maternal health supplies, which led to a set of recommendations that we presented to our executive committee. And this was going on at the same time that the commission was forming and doing its pre-work and prep for its working groups and getting to where it is now, as well as Kristy and Rachel working on the maternal health supplies advocacy end of things, and the maternal health supplies working group that is led by PATH and PAI. So there's a lot of things going on in parallel at the same time. And within the coalition, we're very conscious of that, and our efforts are really to bring our members together and work together in the way that we have done for family planning and reproductive health commodity security for family planning products, and utilize the tools and resources and knowledge that we have internally amongst our members to try to bridge the gaps that exist with maternal health supplies. And so we're moving in that direction now. We have a new caucus on maternal health supplies that just held its first meeting in Paris the first week of October. And we're actually working on a number of proposals for core funding for the coalition that are all going out this month. They all contain maternal health supplies. So I think we'll be having a lot more, you'll see activities coming out, but also our members working on this. And I would just put a plug out to those of you in the room who are from the maternal health community and are not currently members of the coalition to look on our website or talk to me after and consider joining. It's free membership, and currently we have about 215 members, so it's very large. But we're doing a lot of things right now around maternal health supplies, and a lot of that is aligning particularly with the UN Commission. So
Thank you very much, Bonnie. And Debbie, did you want to make
I was going to either call out Jen, who's been working on this, or Bonnie. So we have the same idea.
Great. Other questions? Thoughts? If you don't come up with one, I will. Okay.
Hi, my name is Jessica Whitfield.
And can you stand up?
Yeah. Oh, get all this out of my lap.
Sorry.
Hi, my name is Jessica Whitfield. I'm with the Medill News Service. Mine is directed towards Deborah. You touched on health insurance and public sector versus private sector. Can you elaborate a little more on the difference in quality care between the two, and also any statistics on coverage if they're available?
Okay, so what I was talking about when I was talking about the financial incentives, and you're right, insurance fits in there. But I think for most developing countries, they don't think about insurance like we think about insurance. But I do think that there are many countries, Ghana being one of them, that are looking at how can, we're the only country around that doesn't believe in universal health care. And most countries feel that it is a right of their population, and they're doing their best to figure out how to support the population. And so countries are trying to figure out how do you do that. So Ghana has an insurance scheme, and we invited some of the Ghanaian policymakers to a big financial incentive summit and learned more about what they're doing. So more and more countries are doing that, but there are many, many options. There are voucher schemes. There are, like I said, these PBS performance-based contracts, performance-based incentives. So governments are trying to figure out how do we improve the ability of the population to receive services. So there many different things are being tried now. So I think I could connect you up if you want more information on that with people who are more of an expert than I am. Now your second part of your question was? Coverage. Not great at this point in time, but I mean, you have like a program called JSY and I don't know what the actual local language, what it means, but it's an India program. And basically what they're doing is paying
women to come to facilities for birth. So they have markedly increased the numbers of women who have come to facilities for birth. Now, are we bringing down deaths? I don't know. Because if the quality of the facilities isn't good, and now we've got a whole bunch more women coming to facilities, I think we need some evaluations to find out how well they work. So, there's a lot of things going on now, people really trying lots of things. So I think there are people, again, who could lay it out, give you some more literature on this. And I know it's growing by leaps and bounds, but what the coverage is, I don't know that I could speak to. Did you want to?
Just another country example that has adopted a health insurance scheme that, from what I've seen and read, is working quite well is Rwanda. And I think there was a health policy and planning article, if you want to look it up, on the insurance scheme in Rwanda that was quite impressive. Can I ask a question, Rachel?
Sure, go for it.
Sorry. I was reviewing the report as well as the implementation plan from the Commission on Commodities, or ComOnComs as it's sometimes called. And it's an incredibly impressive and well thought out piece of work. I think the question that many of us in the community have had from the beginning is, these are 13 incredibly important commodities, but they're not the only important ones out there. There's, manual vacuum aspiration. There's a whole bunch of other technologies across that reproductive, maternal, newborn, and child health spectrum that honestly meet the criteria that the Commission set out. I think, there was a discussion, I know, within the reproductive health, family planning commodities around IUDs, and there was a big push, actually, from the community to get IUDs included. So I would be interested to hear from those of you who have been actual members of the working groups really involved in the Commission's work. I know many of the recommendations are cross-cutting, but a lot of the recommendations are also very specific to these 13 commodities. So what is the thinking around that, and what's the prospects for?
This is the beginning. I don't know. That's how I would answer it.
I don't know how they were. I don't know how they were all selected. So maybe it would be helpful.
I don't know whether Jagdish, do you want to go first?
And I think your question is very pertinent, particularly in family planning commodities. I get lots of questions saying that, why did you pick up only 3, whereas family planning is not about the product, it is about the choice. Yeah. And how can you confine in 3? And I think, and supplies coalition issue came because when the commission was being established, family planning part was not there, and we all worked to convince that family planning makes a big sense in terms of reducing maternal mortality. Then the question came that we can't take whole lot of commodities, only underutilized commodities. And in terms of family planning, what that means, because every commodity is underutilized. If you think in some ways, IUD is also underutilized. So, but looking at the potential for seeing that how it's not about high impact, but it's in the sense that where resources or the policy can make some changes. We went to RS Supplies Coalition Executive Committee in Seattle and discussed, and the coalition gave the recommendation that if you have to confine in only 2 or 3 commodities, we will say, female condom, because that time there was only one manufacturer, and we couldn't do much about it. It's also high price. Emergency contraceptives, because various issue of the counterfeit and the quality issues and promotion issues and talking about it on demand and all those things was there. And then implant, because it was very, very high cost. That time we were talking probably $21 per piece, and we didn't have resources. So every time countries were asking us, asking me particularly, because I was sitting in that chair, that give me implant, and I was rationing. I said, we can't give you because we don't have resources. Can you do something else? And it is criminal because you don't have resources and people are asking for it. So we always went back to donors saying that please help us because there is a demand and we don't have resources to meet, and we are rationing because there is no money, government is not putting the money, and they are saying that we don't have that kind of resources, they have to use what is available. So we pushed the international community, and we are thankful to many key donors who supported for implant work, and then this price negotiation. So there were very specific region that we picked up some of the commodities. It does not mean they're all, it does not mean that it serves everything for maternal health. I think what it will do in next 2 years is basically put the system which can be used for other thing, put the market dynamics which can be used for other thing, but give highlight in some of those areas. It does not mean that UNFPA will stop, talking family planning in a broader sense or maternal health in a broader sense. But this is a specific work, and that's how we took it. But the recommendation that we are working is very outreach. I mean, it can go beyond those 13 commodities. I think that's what, David, you are trying to say.
Yeah, I think Jagdish has pretty much said. I mean, we had from the maternal health side, why aren't antihypertensives on there? I mean, of course there are other meds, but you can't take them all on. So that's.
I would also just say this is where I think advocacy at the national level is also going to be extremely important, because as they move forward to developing plans that meet their specific country context and their needs and their desires, as advocates, as program implementers working on the ground, we need to think how to use this platform and this space to actually to also ensure that other commodities can be brought into the mix.
Yeah.
And I do think that's incumbent upon us as a community. So.
Marguerite Papiano, DAI. Several of the speakers and even questions from the audience have underlined or underscored the importance of quality assurance. And given the time limitations, though, for the presenters, I wondered if are there examples of more or less well-functioning quality assurance programs that are setting an example and that could be used as a template or a model in other, more globally?
Maybe Kennedy, you want to start,
for
and
that.
then we go to Debbie?
That's a very tough question to ask. I think it's very difficult to really use it as a one-size-fits-all. I mean, what I would say is, I think are you looking at quality assurance at national level or the whole process of procurement to patient?
I've been involved over my career in a lot of evidence-based action, and I would just ask, I know how tough putting into place a comprehensive quality assurance program is. So the follow-up question would be, is there a well-functioning quality assurance program at any level, in any place, in any specific
could be used.
area that is out there?
I think I was trying to avoid self-promotion. But I would say that USAID has been able to do that. And the two examples I'm going to give, perhaps if you look at the PEPFAR procurement for the medicines, for ARVs, there is quality assurance system for the procurement end of it. I'm not sure about the end part of it to the patient. But then there's also another program that has been in partnership with US Pharmacopoeia, which is currently promoting the quality of medicine, which I'm representing here. Previously used to be DQI, or Drug Quality and Information. Essentially, we've created some systems that we actually are able to more or less customize it to a country needs and country level. And we work with the country in terms of trying to strengthen their own quality assurance system in country. There's also a sister program, which is CAPS with Management Sciences for Health. That also deals with the procurement end of it. But the system that PQM has developed is able to actually go in country, and we're able to actually work with the regulatory agency and try to actually, in most cases, what we normally do is put up what we call MQM, that's Medicine Quality Monitoring Systems, Centennial sites, where we'll do some sampling of medicines in country and try to find if there's any counterfeit medicines in the country. We'll train them to actually have enforcement. And there's also push to get regional cooperation. Recently, I was involved in a meeting. We formed a group in Southeast Asia. It's actually, the acronym is BREMER, essentially trying to bridge enforcement and medicine regulatory agency knowledge together and actually sharing knowledge across the borders. So that's involving 6 countries, Indonesia, Philippines, Vietnam, and all those countries, essentially trying to work together and trying to use their knowledge and really build up in terms of capacity building. So if you're really talking about there isn't one size fits all, but it's a question of really trying to seek the appropriate needs for a country. If it's assessed, in our case, what we would normally do is go in and provide assessment, see where the needs are. If it's quality control labs, we'll work with that. And whatever it is, I mean, another example I can give you is we've been working, for instance, with Russia, FDA. That's rostravnazole. And essentially with them, it's a pretty much high level. They are much more developed than most countries we are working with in Africa. But with rostravnazole, what we do is we provide USPs, the so-called PE courses, which is pharmacopoeia education courses. So we will tailor-make whatever is needed per country to sort of build their quality assurance systems, quality assurance and quality control.
So I think one of the answers there is looking at the PEPFAR model and ARVs, but also looking at some of the capacity building models. There's also been some regional harmonization efforts that you probably know about
Yes.
that are looking at enhancing joint reviews and that may help to address some of those challenges. Debbie, and then we had a question from
Yeah,
Tim.
this is completely, you know, it's interesting. I don't know where she was going from. I mean, this is the whole drug quality.
Yeah.
But I was going to talk about, look at Niger. I mean, I think that there are quality assurance programs that are more connected to facilities. It's a very different kind of quality assurance. That's what I was talking about. So I think Niger has had, from what I've seen, you know, I think the, since you were saying, you're actually naming names, I mean, the URC program, and it's actually USAID, but it's, I think it was health care improvement, and then before that, Q something, I forget the name of the actual program, so I'm not doing a very good job of name dropping, but they worked in Niger over, I think it takes time. I mean, I think that's the one thing you've always got to realize. Our programs too often are 2, 3, maybe 5, but I think they had the opportunity to be in Niger for close to 8 years, and they've gone, and 8 years later, it is still working, and I think there was recently a big publication about how Niger has, you know, and a very poor country, dropped mortality rates on a number of levels, and I don't know that they highlighted that program, but I bet it had an impact. So that would be a place I'd look.
So Jagdish and then to Tim.
I have to give you an example of family planning. I think otherwise family planning parents will not like that. In terms of family planning, and I take the quality assurance not from the national quality assurance perspective. I'm taking more global level. In terms of family planning, we work, all major agencies, USAID, UNFPA, we all try to aggregate demand to negotiate with the manufacturer, which is a good thing that we started doing. All agencies who are the major procurers, they sat down together saying that what are the total demands, how do we aggregate it? And we made a big dent in price reduction. I mean, this is the price reduction that we have in Commodity Commission. We did we did a negotiation before also with some implants, so they reduced from $23 to $18. So that was because we were together, we aggregated demand, we negotiated. We also established pre-qualification ERP process. So I just wanted to tell you, even you know, we got the recommendation from ERP for misoprostol and oxytocin, so that we are ready to buy. We start another new thing, and putting family planning in accelerated process. We also, from the help from the Gates Foundation and others, we went to every country and looked at their national regulatory system in terms of family planning lab and tried to train those people, because some of those labs were very old specification, and we tried to help them. We are still doing it in many national labs. We are trying to give them lab training, and particularly with the Gates Foundation, they invested so much on the quality. So there is a family planning movement that we can learn from them, but there is a progress. In terms of within the national, I think that your question will come next probably, that what we are doing at the community level, if it goes to community level, how do we ensure that the quality is the same as at the central level, and how long you keep it, and all those issues. I think we have to do much more, but I think there is a progress that we can say. Even ISO certification that we got it, and UNFPA is one of the first agencies probably who got ISO certification in terms of international procurement, which is a good news.
Tim?
Thanks. I have a loud voice. Hi, thanks. Tim Thomas from Maternal Health Task Force again. A couple questions on quality assurance. For you, Dr. Kade, I'm very interested in the idea that we could assure quality through better policies in regulatory agencies in developing countries. Am I missing that point? Is that basically what you'd like to see is beefing up the regulatory agencies, better policies, better implementation of those policies, and better enforcement? Is that the answer?
It's part of it, yeah.
Because I wonder how functioning and how pragmatic that is in terms of actually assuring quality at the community level, at the healthcare facility level.
Healthcare facility. I think what I was alluding to, especially the specific questions about local manufacturing, where I indicated you have to demand quality, that should be part of procurement agency demands. But at the regulatory agency level, you also need to have the proper legal framework that enforcement can take place. I'll give you examples. When we started working in Liberia, there was no law. Essentially, everybody was selling any trash on the market. And we did sample. 80% of anti-malarials had no active ingredients. So there were just nothing in there. And at that point, they couldn't take anybody to court. Nobody could go to prison. About 2010, we actually helped craft a law to actually establish a regulatory agency in country. At this point now, at least there's a law now. There's much better flow of quality. We're still sampling on the market. So the pragmatic approach is actually you establish centennial sites. You also start training the staff. So it's a whole beefing up. I think if you really look at our own country here, you have to go back to 1936 at the formation of the FDA. Why? What happened? People died because they took the wrong medicine. And Congress eventually decided, well, guess what? We're going to have some drug law in place. And that's how we get the FDA and the enforcement. So the enforcement is important. So at national level, in Africa, for instance, the general knowledge is that 10% or 30%, there is nothing. There's no regulatory agency at all. 30%, there is something in place. And the other 30%, like South Africa, they really are quite functioning. So you really have to look at specific situations. But yes, it's possible to actually change focus in country once you have the appropriate law, policy, and everything. And the capacity building and training is very important. But that training as well shouldn't just be limited to getting per diems. There has to be institutionalization of that training.
Thanks. Just one follow-up, Rachel.
Sure.
One of the things that I think we learned from the ARV experiences and that you alluded to back in the 90s was the demand that was created by community-based advocates. Mm-hmm. This was not a top-down approach. As a matter of fact, governments were reluctant, as you say. They were siding with traditional medical communities in terms of not wanting to distribute ARVs massively and at the community level because of issues around the complexity of application and also resistance. And there was a bit of financial incentives there. So I'm not sure. The lesson that I think we could learn from the AIDS movement in the 90s and early 2000s in demanding ARVs is not necessarily around quality. I think what we have to get, what my suggestion, or I'd be welcome to hear the panelists, is getting back to what our colleague over here said earlier about how to create demand at the community level. And not only in maternal health commodities, but in maternal health services in general. And this goes back to a meeting we had, Debbie was there and Ann was there, that a while back, that where is the urgency? Where is the demand? Why is the demand not coming from community providers and patients themselves? And are we misplacing our resources by working top-down, by regulatory enforcement, for example, as opposed to demand for quality care from the people who need it? I'll shut up now. Thanks.
No, I think that's a great statement, and I'm going to add my 2 cents, even though I'm the moderator.
That's what you get to do as moderator.
As an advocate, which is my full-time job, I would say it takes both. We're going to need top-down, and we're going to need global leadership and pressure, and we're going to need bottom-up. It's going to take both. And any successful advocacy has never happened without both of those. But you're right. The bottom-up part has to be there. And one of the reasons why we pulled this group together to get and met with people from many countries around the fact that these commission recommendations were coming out was so that they could start being aware that this dialogue was happening at the global level and think about how they were going to use that potential platform for community engagement. Because, there haven't been many opportunities or windows of opening for communities to get engaged in these issues. And this might be one of those unique opportunities where communities can mobilize. We were really pleased that there was a meeting in Abuja with, I don't know how many ministers of health ultimately ended up being there, but 4 or 5, but but that's the ministry, that's not the community. Hopefully, what we'd love to see, and I think part of it, the big question mark for us is the how are we going to do this? Communities, there will be an opportunity for community mobilization around these issues as there is a spotlight at that global level. I think you're right, though. We have a lot to learn from the AIDS community. You and I were both back there in a while back, but there has to be a catalyst. And then there has to be support and engagement and outrage. And so I think you're right. We talk very academically about what needs to happen here. But I think Jagdish started by saying it very well, is women shouldn't die from something that we can prevent. And where is the outrage in that? And I think, we can be very polite and here in this panel in talking about what needs to happen from the bureaucratic angles of things. But it's also going to be people not accepting it as it is. So that's my editorial. Thank you, Tim.
I fully agree with the community-based demand. But in terms of family planning and prevention versus treatment, I find there is a big difference. The treatment people demand from the community level. Mm-hmm. Prevention is, particularly family planning, there's a demand, but who hears them? There is an unmet need. That's the demand if you take it. Every country has unmet need. Why? Any time we talk family planning with the Ministry of Finance, it's not Ministry of Health. Ministry of Finance, we talk, the first thing they cut is the family planning budget. And is that the assumption that there's no demand? No, this is wrong. They have a demand. We go to the community level. They walk 2 hours. They don't get their product. And so it's not community, they don't have demand, because we have established with the data that there's a demand. I think the issue of women, who will take care of them? Who will think that their body and their family is more important at the political level? I think that is something that we all have to push for it. I think ARVs and HIV community has given a good lessons. But I think in terms of, maternal health, we can discuss. It's a slightly different area, but family planning sometimes is a bit frustrating because we don't have the same type of big advocate and celebrities. Probably we need to have it. But community level, what we hear, the people, they are in those places and that group where their voice is not heard to the highest level. And that's where we need all of your support, because they are the unheard voice at the corner of some countries with the less educated. I'll give you an example of Sri Lanka. In my days when I started doing family planning, I thought the Sri Lanka family planning was one of the best at that point of time. The region was women were so literate, probably more literate than many of the Western countries that I knew that time. But in last 18, 20 years, I think because of war and everything. So if women are educated, illiterate, I think it becomes much better. But how long we can wait for women to be literate and so that they can demand and they have a facility to do it? In the meantime, we have to continue doing prevention as we are talking about it. And so family planning areas is where I think we have to do more because it's a prevention. And it's very, it's the area that we need to support.
We only have 6 minutes left. I have one question here, and I wanted to give one last, what I'm going to ask each of you, so I'm giving you a heads up now, is for you to be able to tell this group what they can do. So I'm going to have you wrap up with each of you taking very quickly saying that. I want to take this one last question. I apologize. I know there were other hands up, but hopefully afterwards you can ask the panel some questions. So if you can ask your question, if you can be very succinct with your question, and you all can be very succinct with your answers, that would be great.
Okay, I'll be precise. So I've heard two words that I'm afraid they were used a little bit interchangeably, and these are demand and consumption. I think the impetus for demand is need, and the impetus for consumption is access. So, Kristy, you're talking about data and data tracking and analysis. How do you, in the ground, analyze these two big, I think, parts of consumption and demand?
That's actually, I will be honest, I'm an advocate, and so I would actually love to turn to some of my colleagues on this who are more of the familiar with the technical. What are the best ways to sort of approach that information and that work?
That's really getting us.
Data, how do we use it? How do we get the right data?
I know how to use it.
Yeah.
You know how to use it, but how to collect it. Is that really the question? How to
Yeah, because, I mean, demand, right? I mean, people have needs, right? But then consumption, well, you need some sort of access.
So again in terms of if we take the lessons learned from family planning, Edward is, I think he left from Deliver. He has been doing this work for 25, 30 years. I know Deliver is good. And policy, yeah. In family planning, we collect both what is being consumed from the bottom up, and we also see the supply data. We call logistics management information system. We match and then see that how this is done. In terms of maternal health in Abuja, that's what they are saying, that we don't have consumption data in many countries to see that exactly your point, that what is being consumed and need versus demand issue, and then see that how they match or not match, and that work in maternal health. And that's what I was saying, that they are not in different level of development and knowing what exactly is needed. And all of us are saying the same thing. In maternal health, we have to do this work more in every country level so that we can come to the level of family planning. In every country, the family planning group have consumption data? No, but that's how we started. In many countries, we do have consumption data and supply data both to see where are the stock out, which district, and even we have a computer system to check in many countries. So that's the lessons learned.
Okay.
I'm going to actually just go to the panel. I think that's a great challenge for us. So it's a good thing for us to remind. It's not just data is this monolith. We need a better understanding, and it goes back to the community. I am going to ask you to start with Anne and go down here. What can these people, these people have sat here and spent a lot of their day with us talking about these issues. What can they do now?
I'm going to answer that with a two-part answer. And the first is to read and use and disseminate and use the report, and in particular the implementation plan from the Commission on Commodities in your daily lives, night and day.
Wow.
Okay, that's a little strong, but it is. They're really good products. I mean, there's a lot in there. It's 13 commodities. It's 10 recommendations. There's sort of these cross-cutting themes, and then there's the commodity-specific recommendations. But it's really, a lot of people put an enormous amount of effort into thinking this through. And there are issues. There are some commodities that aren't included. Maybe there are. You can always pick at things, but overall, it's an incredibly good product. And if all of us as a community come together behind it and talk about it and use it in our work at the global level and at the country level, then that's really going to help the recommendations be taken up and used and rolled out, and perhaps most importantly, funded. My second point is just to pick up on this question around engagement with community. I think we need to be very clear that in family planning and maternal health and everything else, unmet need does not, in fact, necessarily mean demand. Depends on definitions.
Exactly.
But unmet need is saying this product, this commodity, if it were used, if it were disseminated, if it were administered, could save lives. Demand is, are people aware of the fact that this commodity should be available and should be used? And I think that's what you were getting at. And I think, just to take one more minute, I think we need to recognize in the field of reproductive, maternal, newborn, and child health, as compared to HIV, that if you have HIV, AIDS, and you don't get antiretrovirals, you will die. If you are pregnant, there is a risk of complications. If you have a complication, there is a risk of dying, but it's not a one-to-one equation. And so the demand side of things, that issue of that urgency, we were talking about the urgency, we need to be realistic about what we can expect. And I certainly think there's a lot that we can do as a community to support community voices and community demand and community understanding of the importance of having these commodities, as well as having a functioning health system, adequate health workers and all that as well. But we need to also recognize the limitations of that there are differences.
Jagdish, briefly.
Briefly. I think it will be, it depends on what we can do. I think for media and communication people, I think we need to talk about this. We should write about these issues. I think if we are technical people, we should talk about continuum care and being together. I think that is the message that I would like to give. If you are a politician, philanthropist, think that the women in Washington and women in Niger are not two different human beings. It's the human being that we have to save both. So I think like Gandhi said, if you want to make change, you have to be changed yourself. And I think that's what the message. It depends on your role and what you can contribute. But I think there is an urgency. We talked about 2015. It's coming very close, and we are far away.
Yep.
Okay, so given that you had the last question, a lot of people are speaking to this a little bit too. I just wanted to throw out something. You brought up Abuja. I think we need to identify champions and the positive deviants. And I will say one of the things that was incredibly powerful in Abuja, the president of the country, good luck Jonathan, got up and said that this, he was talking about they want to save 1 million lives. And I think in general they're speaking of children, but they're also speaking of the mothers who are going to save the children. And UNICEF had a very articulate way of putting, you need both. I mean, I suppose that's not exactly the way to say it, but the mothers save the children, and the children are what the mothers are, that's why they're pregnant. They really want to have these children. But he said, I am one of 9, and my sister and I remain. Everybody else died under 5. He said, and I can still remember some of them. So it was a pretty powerful statement. He said, this is near and dear to his heart. And that's true for a lot of people. So we need, we need to identify those peoples to help us and help educate around demand and why these things are needed. But what I wanted to say is, in terms of what we think you guys can do, I'm actually, along with Jagdish, one of the convener for the Maternal Health Commodities Group. And we welcome, I see this as a very inclusive group. It's called the Technical Reference Teams. Anybody who wants to join us, we need your name to get you on an email list. We're putting together a work plan. Ultimately, it's only going to happen by the work of all of you contributing. And I think one of the things that hasn't come out as strongly as could have is that on a certain level, we're talking global effort here. There's a number of things, particularly some of the things that Kennedy was talking about, and some of the things with manufacturers. But in the end, rubber meets the road at the country level. And a lot of you are groups that work in countries. How do we get the work USP does with the group JSI and MSH and MCHIP and all of the other groups that are here in a country because we're going to need everybody to ensure that, in fact, we get the supplies to the women and children who need them. So lots of work to be done. Everybody's needed. And in the end, it's going to happen at the country level. So I think...
We're going to move on to Kennedy.
Yeah, Kennedy.
Yeah. Thanks.
Quickly.
Very quick. I think it's wonderful to have everybody come over this morning. And thanks for your partnership with us. And what I would just encourage you, and I'm going to highlight again on drug quality, because it's really critical. It's the slow snake killer that goes around and kills people. It's a huge market, $70 billion in general of counterfeit and bad medicines. So whatever organizations, whatever countries you're working in, please try to advocate, try to highlight those issues. Because we may be losing a lot of people to bad medicines, not necessarily to the disease. Which is what I normally find when I visit Africa. You find somebody's had a headache for months. You give them Advil, it's gone. So I really want to encourage everybody to advocate, and for those in the media, please make it a priority for advocacy and knowledge. Because if there's no community action, as the gentleman here pointed out, usually you're not going to have action at all. So if the media can actually support to highlight the issues that we are losing people needlessly, people that shouldn't be dying are dying. So I would really encourage everybody to just advocate as much as possible.
Kristy?
Sure. I will be quick, but right now I do have a direct beeline to Paula now that a lot of people are out of the way, and I feel like we'd be remiss if this point wasn't made during this panel because it came up so much during the policy dialogues and it's in the report, but it's elevate the supply chain. And Paula, I don't know if you want me to quote you, but it's getting the supply chain out of the bathroom into the boardroom. I think you told me that expression before.
Backroom.
Backroom. Oh.
I think bathroom's even better. I was like, how did it get in there?
I have always wondered about that. Okay. Anyways, and so that an emphasis on human resource capacity. This is an incredibly important point, and so that is definitely in the report. In terms of actually how you can be involved, I have 3 sort of very specific things. One, if you're interested in joining the Maternal Health Supplies Working Group, please contact PATH or PAI. It'd be wonderful to have you. Also, PATH is leading the convening on the recommendation 10 around innovation. If you would want to be part of that technical reference group and work on the work plan, please let us know, because we do really need all of these maternal health advocates to make sure that the maternal health innovations rise to the top. We won't be able to take on innovation in every commodity at the time, and maternal health is an area where it's very much needed. So we'd love your feedback there. And then I think that the third thing is, Debbie said, it's at the national level. So much of this is going to be really important and really matter, and ensuring that key stakeholders who are in country, on the ground, are incorporated and included into the commission planning going forward to national level plans. And we're at PATH trying to think right now how to do that. How can we emulate a process that was taken here in terms of the maternal health supply master reports to make sure the community's feedback was being sent up into the commission at the global level. That needs to happen at the national level as well. So if you're interested in working on this issue, please let us know. We're trying to make connections in the different countries where people are mobilized and focused, and it would be great to work with you on that. So thank you.
So I'm going to just say one really kind of tactical thing. Each of you works for an organization that has a range of priorities. What I would ask of each of you is, when you go back to your organization, talk to someone about this issue. Make this an issue that's not just something you come to an event and care about. I know your organizations care about these issues, but sometimes it takes the internal champions and the internal advocates to bring these issues to a higher level on the radar screen within your own institutions. So that's something that I would leave you with. And finally, I just want to thank you all. We've got folks who traveled to be here, who had other things that were happening that were very important and made the time. All of you spent a couple of hours with us now. I just want to thank you, because it's going to take every one of us, and it's going to take a lot more than those of us who are sitting in this room to really make the difference that we need to see. And I hope that you will engage others in this dialogue. Bring them along. We've got open groups. We want to work with people. We're not closing anyone out. So please help us bridge those communities. Help us make those champions. Help us raise those voices. And thank you very much for spending a good part of your day with us.